Hello my dear students, welcome back again to a new video. So today we are going to discuss anterior pituitary hormones. This pituitary gland is called the master endocrine gland because it elaborates a number of important regulatory hormones. The secretion by pituitary gland is controlled by the hypothalamus by various releasing hormones or release inhibitory hormones. Now there are two lobes. This pituitary has two lobes. One is the anterior lobe and other one is the posterior lobe. The posterior lobe of pituitary releases oxytocin and vasopressin, whereas the vasopressin is antidiuretic hormone, whereas the anterior lobe they secrete ACTH, that is Adenocorticotropic hormone, TSH, thyroid stimulating hormone, growth hormone, luteinizing hormone, follicle stimulating hormone and prolactin. This release of various hormones by the pituitary is governed by the hypothalamus, like GnRH, that is thyrotropin releasing hormone, which is secreted from the paraventricular nuclei in the hypothalamus, released to stimulates TSH secretion. Corticotropic releasing hormone stimulates ACTH secretion, and somatostatins inhibits growth hormone secretion. The arcuate nucleus of the hypothalamus releases growth hormone releasing hormone that stimulates growth hormone release from the pituitary, gonadotropin releasing hormone which stimulates gonadotropin release from the pituitary, and dopamine which inhibits prolactin secretion from the pituitary. So we will discuss in details about all the hormones of the pituitary, mainly the anterior pituitary. So the hormones secreted by the anterior pituitary are structurally classified into somatotrophic hormones, glycoprotein hormones and POMC derivatives. POMC is pro-opiomelanocortin. Somatotropic hormones are growth hormone, prolactin. Glycoprotein hormones are TSH, that is thyroid stimulating hormone, FSH and LH. FSH is follicle stimulating hormone and LH is luteinizing hormone, which are together called the gonadotropin. The POMC derivatives includes ACTH and MSH. So first let's discuss the growth hormone. This growth hormone is a 199 amino acid single chain peptide. They promotes growth in all the organs by inducing hyperplasia. They generally acts through JAK-STRAT protein kinase receptor. The main metabolic effects is induced through IGF-1, which is also called insulin-like growth factor 1. Now let's see the regulation in this picture. The hypothalamus secretes growth hormone releasing hormone which stimulates growth hormone secretion, and hypothalamus also secrete somatostatin which inhibits growth hormone secretion. So hypothalamus has both positive as well as negative stimulus on growth hormone. This growth hormones acts on various organs like the liver, bone, adipocytes and muscles, which further elaborates IGF-1, that is insulin-like growth factors, which acts on the secondary tissues, and the major metabolic effects of growth hormones is generally due to this IGF-1. Now remember one thing, growth of the brain and eyes are independent of the influence of growth hormone. Liver is the main source of IGF-1. The IGF-1 secreted by the bone, adipose tissue, muscles and other tissues generally acts on them in a paracrine nature. Now, what are the pathological involvement of growth hormones? So, in cases of hypersecretion, we see gigantism in cases of children, gigantism, and acromegaly in cases of adults. In cases of hyposecretion, we see pituitary dwarfism. Different preparations of growth hormone available to us are the recombinant growth hormone, somatotropin and somatrem. They are used in pituitary dwarfism. Now, they can only be used to promote growth if the epiphyses are open. They are also used in Turner syndrome and in renal failure seen in cases of children. Growth hormone is used in AIDS related wasting but not in critically ill and cancer patients. So, only in AIDS related wasting. Now, one thing must be noted here, that use of this growth hormone is absolutely banned in cases of athletes, and this growth hormone is included in the dope testing. So, this must be remembered. Now, let us talk about the growth hormone inhibitors and where they are used. Somatostatin is a growth hormone release inhibitors. Octreotide, lanreotide and pasireotide are somatostatin analogues, which are release inhibitors. Just like somatostatin. So, somatostatin, octreotide, lanreotide and pasireotide are growth hormone release inhibitors, whereas pegvisomab is a growth hormone receptor antagonist. Okay. Out of this, octreotide is mostly used, which is a longer acting and a more potent somatostatin analog used in cases of acromegaly, secondary diarrhea due to carcinoid, VIPomas, that is vasoactive intestinal peptide tumors, Zollinger-Ellison syndrome, AIDS and cancer chemotherapy. So, this is very important. They are used in acute variceal bleeding seen in cases of chronic liver disease patient, that is the esophageal varices rupture due to portal hypertension and there is bleeding and patient comes with hematemesis, very serious condition. So, octreotide is used in acute variceal bleeding. They are also used in bleeding peptic ulcers and in cases of pancreatitis as a perioperative prophylaxis. Next is the prolactin. Prolactin is a 199 amino acid single chain peptide. It leads to growth and development of breast during pregnancy along with progesterone and estrogen. But after parturition, it induces milk secretion when the level of estrogen and progesterone comes down. So after parturition, as the levels of estrogen and progesterone comes down, the inhibitory response of this estrogen and progesterone is no more, and prolactin leads to milk secretion. Just like growth hormones, they also act through JAK-STAT receptors. One thing must be remembered, prolactin inhibits the hypothalamo-pituitary gonadal axis. Hypothalamo-pituitary gonadal axis means release of FSH and LH. Therefore, high levels of prolactin inhibits hypothalamo-pituitary gonadal axis. That is why we see lactational amenorrhea and lactational infertility. The release of prolactin from the anterior pituitary is governed by TRH, thyrotropin releasing hormone from the hypothalamus, which is stimulatory to the pituitary. TRH stimulates the pituitary to release prolactin, whereas dopamine inhibits the pituitary to release prolactin. Suckling by the infants is stimulatory to prolactin secretion. Now let's see the pathological involvement of prolactin. What happens in hypersecretion? So in cases of hypersecretion of prolactin, it is hyperprolactinemia. In cases of hypersecretion of prolactin, we see galacturia. Galacturia is oversecretion of milk. Amenorrhea due to inhibition of FSH and LH secretion. Infertility. So we see a galacturia, amenorrhea, infertility syndrome. Various reasons leading to this hyperprolactinemia may be disorders of the hypothalamus, that is secreting more and more TSH, use of anti-dopaminergic drugs that will take away this inhibitory response so that more and more prolactin is secreting, prolactin secreting tumors like the microprolactinemias or macroprolactinemias, and in cases of hypothyroidism. Why? Because in cases of hypothyroidism, we find a high levels of TSH and high levels of TRH. There is no clinical use of this prolactin as a whole, but we use prolactin inhibitors. Drugs like bromocriptine, carbagoline and quinagolide are prolactin inhibitors. Now, how they inhibits? Bromocriptine is an ergot derivative. It is a D2 receptor agonist and D1 receptor partial agonist. So bromocriptine is a agonist of the dopaminergic receptors. In the D2 receptors, they are agonist, and in the D1 receptors, they are partial agonists. Now, one thing you must remember, that is a partial agonist in the presence of an agonist acts as an antagonist, right? So a partial agonist in presence of an agonist acts as an antagonist. Carbagoline, which is again a ergot derivative, but it is selectively D2 receptor antagonist. Quinagolide, which is a non-ergot derivative, is again a D2 receptor agonist. These drugs are used in hyperprolactinemia, that is galacturia, amenorrhea, infertility syndrome, In cases of acromegaly they have been tried, but it's better to use growth hormones inhibitors, it's better to use growth hormone inhibitors in those cases. Bromocriptine is also used in Parkinson's disease. Now this we will discuss in a separate class or separate video. They are also used in cases of hepatic coma. Hepatic coma is hepatic encephalopathy, because these drugs cause arousal. Prolactin inhibitors are also used for suppression of lactation and breast engorgement in cases of neonatal death. So, next is the gonadotropins, that is the follicle stimulating hormone and the luteinizing hormones. This follicle stimulating hormone causes follicular growth, development of ovum and estrogen secretion in cases of females, but in cases of males they cause spermatogenesis. Luteinizing hormones is responsible for ripening of the Graafian follicles, ovulation, luteinization of the ruptured follicle, and they also sustain the corpus luteum till the next phase of the menstruation, next menstrual phase to be precise. Luteinizing hormone also cause progesterone secretion. Now these happens in cases of females. In cases of males they cause testosterone secretion and is called ICSH, that is interstitial cell stimulating hormone. This LH is called ICSH in cases of male, that is interstitial cell stimulating hormone, that causes testosterone release. Release of this gonadotropins, that is LH and FSH in the pituitary, is governed by this hypothalamus by GnRH, gonadotropin releasing hormone, which is stimulatory to the pituitary. The hypothalamus secrete gonadotropin releasing hormone which stimulates the pituitary to release FSH and LH. This FSH and LH has their direct action on the gonads, as well as they release various sex steroids which acts on the accessory sex organs, and this sex steroids sends a negative feedback to the both pituitary as well as hypothalamus. So again let's see the pathological involvement of gonadotropins. In cases of hypersecretion we see precocious puberty in cases of children, polycystic ovaries in cases of adult women. In cases of hyposecretion or less secretion we see delayed puberty in cases of children, amenorrhea and sterility in cases of females, and impotence and infertility in cases of males. Absence of or hyposecretion of gonadotropin in cases of both males and females leads to hypogonadism, that is underdeveloped gonads. So next is the various gonadotropin preparation that we have. These are menotropins, which is a combination of FSH and LH, and urofolitropin, which is pure FSH. Now, they are used in amenorrhea and infertility, hypogonadism in cases of males, cryptorchism, that is undescended testis, and to assist in vitro fertilization, that is IVF. Next group of drug is the gonadotropin releasing hormones. Now this is secreted from the hypothalamus. Gonadotropin releasing hormone secreted from the hypothalamus, which stimulates the anterior pituitary to release gonadotropins. Gonadotropin is a synthetic GnRH, that is gonadotropin releasing hormone. They cause rapid release of both FSH and LH. They are only used for testing disorders of the pituitary gonadal axis. There is no therapeutic use. Why? We can always use gonadotropins in their place. Why we will give a gonadotropin releasing hormones? And moreover, the release of gonadotropins by gonadotropin releasing hormone, the release of this gonadotropin by this gonadotropin releasing hormones depends upon the pulsatile release. Pulsatile release of gonadotropins. So whenever there is a pulsatile release of gonadotropin releasing hormone, we see gonadotropins. Once you give a continuous infusion or you give a continuous supply of gonadotropin releasing hormone, you will see down regulation of the gonadotropin receptors, gonadotropin releasing hormone receptors, and there will be desensitization. So due to desensitization and down regulation, this gonadotropin releasing hormone, which was initially increasing the synthesis of FSH and LH, will now lead to reduced secretion of FSH and LH. So therefore we need a pulsatile stimulation, and with the use of these drugs, the pulsatile stimulation, you cannot give a pulsatile stimulation, there will be continuous availability of GnRH, and so you will find rather than increase in FSH and LH, you will find decrease in FSH and LH due to receptor desensitization and down regulation. So therefore they are not used therapeutically, though GnRH receptor agonist, GnRH receptor agonist are used therapeutically. Now these are buserelin, goserelin, leuprolide, nafarelin and triptorelin. Now what is the mechanism of action? Initially they will increase gonadotropin secretion, that is FSH and LH. So initially there will be increase in gonadotropin secretion. Later, due to desensitization and down regulation of this gonadotropin releasing hormone receptors, there will be inhibition of gonadotropin release. Now this suppresses the gonadal function to a castration level. So therefore GnRH receptor antagonist inhibits gonadotropin release. Now this must be kept in mind. GnRH receptor agonist inhibits gonadotropin release. Use of GnRH agonist. We can use them in precocious puberty, where they cause pharmacological oophorectomy and orchiectomy. They are used in prostatic carcinoma, endometriosis, premenopausal breast cancer, uterine fibroids, polycystic ovarian disease, and to assist induced ovulation in assisted reproduction. Next is the thyroid stimulating hormone, that is the TSH, which is a 210 amino acid 2-chain peptide. TSH stimulates the thyroid gland to secrete T3 and T4. It only has a diagnostic importance in cases of hyperthyroidism. The TSH level will be the TSH levels will be low, and in cases of hypothyroidism, the TSH levels will be high. So this only has a diagnostic importance. It does not have any therapeutic importance. Like if a hypothyroid patient comes, it's better to give levothyroxine T4. Why will we give this thyroid stimulating hormone? So it's better to give levothyroxine rather than TSH. Okay, so therefore these are not used therapeutically, only diagnostic importance. Same thing with ACTH, which is a adenocorticotropic hormone, which is a 39 amino acid single chain peptide. They promotes steroid secretion from the adrenal cortex. ACTH only has diagnostic importance for pituitary, for diagnosing pituitary adrenal axis disorders, and no therapeutic use, because we can always give corticosteroids rather than giving a ACTH. So no therapeutic use, only diagnostic use. That's it. Thank you.